Welcome, everybody. Very happy to have many of you joining us for our webinar on combating ethnic disparities in healthcare, a case study of prostate and breast cancer. So my name is Norbert Kwepel. I work at the European Cancer Organization, which is a non-profit federation of 41 healthcare professional associations and 21 patient groups working in cancer at European level. And we are delighted to be working with the European Public Health Alliance on this webinar that is held in the context of Global Public Health Week. A few words about ECO. So our mission is to reduce the burden of cancer, improve outcomes and the quality of care for cancer patients through multidisciplinarity and multi-professionalism. And we mainly focus on policy and advocacy, multi-stakeholder convening, and policy implementation. So of course, cancer inequalities is a very important topic for our organization, including through a special inequalities network that we are operating. And of course, this includes the impact of social determinants on cancer control, as we know from the literature that ethnic minorities and racialized communities in particular are facing a range of discrepancies across the cancer pathway, from prevention to early detection and diagnosis, and from treatment to survivorship. So our objectives for today are to raise awareness on the existing ethnic disparities in cancer care and to connect initiatives in health equity on ethnicity and gender, but very much also to look for solutions on all of these issues. And so we are delighted to have many expert speakers joining us today from academia, the patient community, civil society, and public institutions as well. And so with this, I would now like to pass the floor to my dear colleague, Robert Green, who, as many of you will know, is very much of a leading voice in the field and will be your moderator for today's event. Robert, the floor is yours.
Thank you, Norbert. First of all, really a big welcome to all of our participants to the webinar, and thank you for joining the Global Public Health Week webinar titled, as Norbert said, Combating Ethnic Disparities in Healthcare, a case study of prostate and breast cancer. Thanks also to the European Public Health Alliance and European Cancer Organization putting this together, and thanks to the team also behind the scene. Last but not least, a warm welcome to our speakers and panelists for today. Norbert, you mentioned already what we are trying to achieve and hoping to achieve today. So to all the speakers and panelists, a kind reminder to please keep your microphones and cameras off when not speaking. So during the panel discussion, you are, of course, warmly invited to share your thoughts or respond to remarks at any time. And just to give some basic information, we will have a Q&A function where you can pose questions or remarks to the speakers and panelists, and also a chat function where you can post the remarks to other participants. Now, my name is Robert Green, and I'm the president and founder of the Hunger Thirst Foundation, and I'm a patient advocate. We're going to move on to welcoming our first speakers. Our first speakers are EPHA McGrowder, and first, please apologize, my apologies if I pronounce any names incorrectly. So EPHA McGrowder, Senior Trial Manager at the Institute of Cancer Research, and Rose Hall, Clinical Research Fellow at the Institute of Cancer Research and the Royal Marsden NHS Foundation Trust. They will be speaking about ethnic disparities in prostate cancer. And please remember to use the Q&A function for questions or remarks. Eva and Rose, the floor is yours.
Thank you, Robert. So as Robert mentioned, I am Eva, and I will talk to you today about the PROFILE study, which is a targeted prostate cancer screening study in men with increased risk of prostate cancer. And I will share some of our outreach work that we've done to try and improve recruitment from the Black community. Can I have the next slide, please? So the PROFILE study aims to recruit just over about 1,500 men, aged 40 to 69 years of age, and it's only open to those in the UK. We aim to recruit 350 Black men of African or Black African Caribbean ancestry. And more recently, we had ethical approval to over-recruit those for the family history cohort, which is open to men of any ancestry, and they need to have a family history of prostate cancer, whereby we're hoping to have at least 350 of those undergoing MRI and biopsy. And a few years ago, we opened a third cohort, which is open to all men of any ancestry, but they need to have a mutation in a gene that makes them more susceptible to having prostate cancer. Can I have the next slide, please? So the profile study opened back in 2014. And at the time, it had opened to just two cohorts, the family history and the Black cohort. At the time, the family history cohort was only open to white men from the European background. And when I joined the team in 2016, I found that the team had only recruited just one Black man to the Black cohort, and when compared to 116 white men for the family history. So over the years, one of my tasks was to find ways to improve recruitment, not just to the Black cohort, but to all cohorts of the study. And I will share some of the work that we've done since then. Can I have the next slide, please? So we have, the team has faced a lot of challenges in terms of recruiting to the Black cohort. And one of the first things that I did was to put in an ethics amendment to allow us to open the study to introduce it into primary care so that GP practices could help us with recruitment. And we also designed posters, and part of that same ethical approval allowed us to use things like social media as well as the posters to raise awareness about the study. I also used to take out time out of my working day and just go into Black populated areas within London and just raise awareness by going to barbershops, churches, restaurants, etc., and ask them to display our posters, as well as speaking to members of the public to raise awareness. And we continue to give awareness talks to community meetings and support groups and just raise awareness across the country. And some of the things that we found was that we need to do more in terms of education and combat misinformation that is out there. The community, the Black community, there is a great deal of lack of trust within the community. Cancer remains a taboo subject. And one of the most important things that we found is that anything to do with prostate, discussion of anything about prostate is within the Black community, men see it as a challenge to their masculinity, their manhood. So we need to approach it with a great deal of privacy. So when I said that earlier, I would go to places like barbershops and ask them to display our posters. One of the reasons why we didn't find a lot of engagement from that was because having these posters displayed in open spaces, these men could not be seen by their peers to show interest in something to do with prostate. Whereas after we learned about the importance of privacy, we were then able to go back to these public places and ask them to display the posters in, for example, like in toilet cubicles, because when men are in there, it's private. They can take down our, contact details, get in touch with us directly for further information about the study. And then, so we did this with football stadiums as well. And then during the pandemic, we co-produced an awareness video with members of the public from the Black community. Some of them were patients or just general members of the public, and they guided us in terms of the content of the video, the location of where this video would be filmed in a way that would resonate with them within the community. And they decided that this video should be recorded in like a barbershop, because in the Black community, a barbershop is a place where they can really talk about multiple, topics, including health. So that video was done. That's the link to the video in case anybody wants to have a look at it. And from that particular project, the men that were involved in the group also agreed to be co-authors on the publication that we produced from that. Can I have the next slide, please? And then more recently, last year, our team had a joint event. So this was designed with the Institute of Cancer Research, the Royal Marsden Hospital, and Prostate Cancer UK, whereby we had a stakeholders day and we invited members of the public, patients and the support groups that we work with to come over to us and hear about the research that is being done within our team, and to meet the researchers, give us feedback in terms of the research that we do. The event was well received, and some of the feedback that we got from that is shaping how we do our research going forward. So collectively, can I have the next slide, please? Collectively, all of these things are helping to improve recruitment, and I'm happy to say that for the profile study, at least for the Black cohort, we've recruited over 300 men. So more needs to be done to improve recruitment and engagement from the community, but these are some of the things that we have found that they've helped us to engage more with these men. I think the next slide is the last one. So yeah, thank you. If anybody's interested in getting in touch, those are our contact details. So thank you very much for this opportunity. I think I'll hand over back to Robert.
Well, yes, thank you, Ava. And I think we have just a bit of time. You mentioned that when you joined the team, you realized that there was just only one Black man recruited, Ava. So I was just curious, what was your first step after coming to that realization?
So it was the way that the study was designed in terms of how it would recruit. At the time, the study was, the ethical approval they had was to recruit through secondary care, through hospitals. And for the clinicians on the call, you're facing patients who are diagnosed with prostate cancer, and you're asking them, the profile study is a screening study. You're asking these diagnosed individuals to take information to pass on to their friends or relatives who are not yet diagnosed. And within the Black community, men usually don't even share that information with their friends that they have been diagnosed. So whilst that process was working well for the white cohort, for the white men, it wasn't, fitting for the Black men because they don't share that information openly with their friends or relatives. But if introducing it in secondary care, the GPs could send out invitation letters to their healthy men, tell them about the study, and it's the men themselves making a decision whether they want to take part in the study in the privacy of their homes by contacting the team. So that's one of the key ways that we improve recruitment, by changing the recruitment pathway.
Okay, thank you very much. And it's wonderful to hear as well the steps that you took about going into the community to reaching the Black men, and also even like recording a video in the barbershop. And what stood out as well for me is the importance of privacy within the Black community. So thank you very much. Now we'll move forward to our next speaker, Rose Hall. Rose.
Hi. Hello, everyone. Thank you so much. My name is Dr. Rose Hall, and I'm a clinical research fellow in cancer genetics at the Royal Marsden Institute of Cancer Research. So as we've discussed, as a team, we noticed that there was a lack of diversity in the referrals that we received to our prostate and genetic screening services. And we wanted to find out why this is the case and what can we do to improve representation from the Black community within our research. Next slide, please. So we have performed qualitative research to understand the barriers and facilitators to participation in prostate and genetic research within 3 underrepresented communities. So this kind of research uses interviews and focus groups to elicit data to answer the research question. And we ask open questions to prompt group discussion around our topic of interest. Next. Thank you. So our findings from those with Black African and Black Caribbean ancestry are that people in the Black community don't talk about cancer, and sometimes people don't know that their relatives have prostate cancer or even know how their relatives died. Therefore, they cannot measure their own risk of prostate cancer and therefore may not seek screening. There is a mistrust of conventional medicine and the NHS, which is present and prominent in the Black African and Black Caribbean community. And the history of Black people being exploited in medicine and research, even in recent history, has caused this. For example, the Henrietta Lacks case or the Tuskegee syphilis scandal. Getting a GP appointment in the UK can be hard, and some GPs are reluctant to perform PSA testing, or they may not even be aware that Black men are at an increased risk and should be screened from an earlier age. Some people are unaware of the relevance of genetic testing in cancer and its availability, and there are concerns that genetic testing might cause problems with insurance and mortgages. And Black men sharing their lived experience of prostate cancer and genetic screening is a facilitator to accessing genetic services. Next slide, please. So, the goal of this work is to improve health outcomes for the underrepresented in prostate and genetic research. And we shall use the data that we have gathered to produce tailored, accessible, and acceptable information detailing prostate cancer screening and genetic risk measurement for individuals who are underserved in society and research. So we feel that we have gained essential trust within parts of the community, and we've gained collaborative relationships, which we will continue to promote and to sustain. Next slide, please. So our outputs will be made according to the co-production approach. So the community champions and stakeholders that kindly have worked with us in our work are co-authoring our papers, research papers describing our research findings, and they're also assisting in the co-production of animations and web materials to explain genetic risk in prostate cancer, especially aimed towards the Black community. Next slide. So that's it. I'd like to thank all the amazing and really inspiring individuals that worked with us. These are just a few. So thank you so much for your time. Next slide. I think it's the last one. Thank you.
Thank you so much. I have one question as well. You mentioned about the distrust. So
yes.
How do you address the distrust without giving a feeling of actually dismissing that distrust itself?
So how we're going to do this is we've built these relationships with cancer support groups in the Black community, and we are having a two-way relationship where we go and talk about increased cancer risk, and we answer questions, and we're hoping that will enable trust to build between us and those groups, but that's only locally. Going forward for our outputs, such as our animations and web materials, we plan to acknowledge the past injustices in history, acknowledge them and acknowledge the damage that they've had, and try and provide reassurance that we have regulations in place to protect individuals and their data, and promise that we will be open and transparent about everything that we do going forward in terms of investigations and the protection of any tissue, such as genetic information and blood samples, and that we will only use them for purposes to assess genetic risk. So that's the first steps, but that's why we have a panel of individuals from the Black community who advise us at every step of the production process. So they advise us what we can do best to try and address the issue of mistrust.
Thank you both for the fabulous work that you're doing for the community. Thank you.
Thank you. And another thing that also I think is really helpful is that these animations will be shared by the community champions within their own networks. So some of these individuals have thousands of social media followers, so they will be the ones sharing the information, not us. That will help, hopefully.
Thank you again. Thank you.
Thank you.
I will now like to invite Toril Gatani, Associate Professor and Consultant Breast Surgeon, Cancer Epidemiology Unit from Nuffield Department of Population Health at the University of Oxford, to speak about ethnicity and breast cancer incidence. Welcome.
Thank you, Robert, and thank you for the invitation to speak today. I'm just going to give a brief overview of the epidemiology of breast cancer in the UK and then speak specifically to breast cancer incidence in ethnic groups. Can I have the first slide, please? So just to contextualize cancer incidence, these are the latest cancer registration figures for England, and we can see that amongst women, breast is by far the most common cancer diagnosed, with about 50,000 annual cases recorded, and this represents about a third of all cancers diagnosed in women. And similarly for men, prostate cancer is the most common cancer diagnosed, and again represents about a third, 25% to a third of all cancers diagnosed in that group. Next slide, please. And we need to consider what the routes to a diagnosis are for breast cancer. So in the UK, we have a publicly funded healthcare system where access is free at the point of care as long as you're diagnosed with a general practitioner. And we can broadly think of breast cancer diagnosis to be that of early detection, where we screen asymptomatic individuals with mammographic screening. And in the UK, we offer 3 yearly mammograms to women aged 50 to 70, and early diagnosis for patients who have symptoms. And this requires prompt referral from primary to secondary care, and they can be triaged by their general practitioner as being an urgent or a non-urgent referral, and this can happen at any age. So we have symptomatic presentation, which could be urgent or routine, and then those cancers which are picked up by screening. And the figure that you're looking at the right of your screen shows you the proportion of cancers that are diagnosed via those routes. And these are data that go from 2006 to 2022. And we see here that approximately half of cancer referrals follow an urgent referral, about a third of cancers come via screening, and less than 5%, less than 1 in 10 cancers are because of patients being referred with symptoms that are considered to be non-urgent. And you'll all note that in 2020, there was a difference in the patterns, and this was due to the pandemic, as screening services in England were paused for about 6 months. And so we had a dip in cancers that were picked up through screening and an increase in those that came through the symptomatic service. Next slide, please. And then let's consider the importance of age with respect to a breast cancer diagnosis. And this graph here is showing you in the pink line an age-specific cancer rate. And essentially, as women get older, the proportion of cancers diagnosed, the age-specific rates go up. And the dark blue lines are the proportion of cancers diagnosed within of those age groups. And what this shows very clearly is that there is a bulge in cancer diagnoses in women who are aged 50 to 70, those in screening. And that's about 50% of all cancers are diagnosed in that age group. And amongst those women, 6 out of 10 cancers will follow routine screening. Only 16% of cancers are diagnosed in women under the age of 50, and a third of breast cancers are diagnosed in women over the age of 70. And then I thought it would be of interest just to see what the actual numbers are. So this is in the population in England, which has an overall population of about 60 million. And we're talking about, in these age groups, of an annual cancer incidence in terms of actual numbers, even in the most common groups, of around between 5,000 and 6,000 cancers a year. And next slide, please. And then just to give you a little bit of history, and I think when you're looking at ethnicity research, it's important to understand the makeup of the population that you're researching. And there's a long history of immigration into the UK, but prior to the end of the Second World War, this was all very small scale. And it was estimated in 1947 there were about 20,000 non-white UK residents. And the top 2 pictures that you can look at, one of them shows an Ayers home in the East End of London. Ayers were nannies who were often brought by Britishers who had been abroad to look after children on long voyages home. And then once they came back to the UK, were quite often abandoned and then went to live in these homes. And the other picture of the sailors, the Lascars, who basically serviced the vessels of the East India Company and its subsidiaries, and similarly could not always find passage back to their home countries. But in Britain, the 1948 Nationality Act basically defined British nationality as the citizen of the United Kingdom and the colonies. So basically, all people who lived in any part of the what we formerly called the empire were entitled to move to Britain to work and live and have nationality status. And then we see successive waves of migration coming, so and largely to work in institutions that were being built after the Second World War, like the health service, the post office, transport systems, etc. Next slide, please. So if we look at our non-white population changes in England and Wales, we have a census every 10 years, and ethnicity was first recorded in the census only in 1991. And in 1991, 94% of people recorded themselves as being white British, and this has fallen to 82% by 2021. So now 1 out of 5 people in this country do not identify as being white British. And with respect to healthcare data, ethnicity has been recorded in primary healthcare records since 1991 and in secondary care hospital records since 1995. And if we look at the changes in the population, so by far our largest discrete ethnic groups are Indian, Pakistani, Black African, and Black Caribbean. And these proportions are increasing over time. And the single largest groups now are those of Indian, Pakistani, and Black African heritage. Next slide, please. And so the latest bit of research that we've published most recently in the European Journal of Surgical Oncology earlier this year was to look at breast cancer incidence in small ethnic groups, in disaggregate ethnic groups. And the aim of our study was to calculate age-standardized and age-specific incident rates in women from Indian, Pakistani, Black African, and Black Caribbean backgrounds compared to those from white British backgrounds. And our population of interest were women aged 25 years and older in England and resident between 2011 and 2019. And all of the analyses used routinely collected cancer registration and census data. Next slide, please. And this first slide is just to show you breast cancer incidence in disaggregate ethnic groups. This first slide is just showing you some census data. And it's just interesting to kind of examine the differences in age of ethnic minority populations compared to white populations. So the figures in pink that you see are the median age, that's an average age of the population, and the numbers in blue are just the absolute number of women. And we can see here that in 2001, take Black African communities as an example, in 2001 there was only 250,000 women living in the UK who were Black African, and this has risen to 750,000 by 2021. Similarly, for Indian populations, 500,000 in the 2001 and rising to almost 1 million by 2021. The only population that remains static are those of Black Caribbeans, and that's largely because of the migration patterns. So Black Caribbean people came to the UK in that first wave of migration, the Windrush generation after the Second World War, and there haven't been successive waves of migration, so it's a population that has remained relatively static. And then when we look at the age of these populations, we can see that ethnic minority populations are generally younger compared to white populations. Black African ladies, median age of 27 in 2001 and only 31 in 2021, compared to a median age of the white population of 44. But we do see that the Black Caribbean population are just getting older. As I said, it's a static population, and in each measurement of the census, we can see that they are just getting older as time passes. And why are these ethnic minority populations generally younger? It's because migrants tend to be younger. They're normally coming for economic reasons, and therefore are going to be of younger working age. Next slide, please. And then looking at age distribution by ethnicity, again from the census data. So in this figure, we're looking at the proportion of women in each of these ethnic groups by their age. So the red bars are under 25, the black bars are women aged 25 to 49, the green bars are women aged 50 to 70, which is that of screening age, and the 70-year-olds are in purple. And we can see quite clearly, just looking at this visually, that there are very different distributions of age amongst these populations. And so if we look at the most recent census data, 2021, for each of these groups, we can see that amongst Black African and Pakistani ladies, over 80% of these populations are under the age of 50 and therefore would not be eligible for routine population-based screening. We can look at the Black Caribbean population, and we can see that nearly a third of them are now eligible for screening, the green bar in 2021. And it's important to contextualize routes to diagnosis for breast cancer in relation to the population demographics to really understand whether there are disparities in healthcare access. Next slide, please. And then looking at breast cancer incidence in disaggregate groups, these are national data looking at the whole of England, and included in the analyses are over 360,000 incident breast cancer cases. And we can see that the annual average number of incidents, C50, varies by ethnicity significantly, with in Black African populations only about 282, Black Caribbeans 346, Indians 569, and Pakistanis 304. And these are national data. So the overall numbers are actually quite small. And when you're thinking about this from an epidemiological perspective, you really have to think about whether you have power to be able to look at certain subgroups within that. And then looking at the rates which are presented next to it, we can see that there is significant difference in the rate of breast cancer between Black African and Black Caribbean ladies, with Black African ladies having a lower incidence compared to Black Caribbeans, whereas Indian and Pakistanis have a similar rate. But overall, all of the ethnic minority groups have a lower incidence rate of breast cancer compared to white women. Next slide, please. And then finally, we looked at age-specific rates. So this is restricted to women who are aged 25 to 49, women who are of screening age 50 to 69, and then women who are aged over 70. And what we can see firstly is that there is an increase in age, that for all groups, there's an increasing risk of breast cancer with increasing age. And we can see that there are significant differences in the age-specific rates of breast cancer compared to white women in all of the groups examined, except for those for young Black Caribbean women, where their rates are similar to those of white women. But otherwise, we see significant differences in all age groups. And final slide, please. So to summarize, there are clear differences observed in the population demographics for women from Indian and Pakistani and Black African and Black Caribbean backgrounds compared to white women. Women from these ethnic groups, except for younger Black Caribbean women, have a lower incidence of breast cancer compared to white women, both overall and in the separate age groups examined. Amongst these South Asian groups, we see similar rates in Pakistani and Indian women in all the age groups examined, but among the Black ethnic groups, the age-specific rates for Black African women are significantly lower compared to those of Black Caribbean women. And these are novel findings. These haven't been described previously, and they give us important information about variations in incidence in ethnic groups, which does require further research to understand further. We need to be thinking about risk factor profiles and whether these vary by ethnicity and how they're influencing incidence, and whether variations in healthcare access are leading to differences in case ascertainment, which then subsequently impact on breast cancer incidence. Thank you very much for your attention.
Thank you very much for that presentation. If I may, I have one question. When you look at breast cancer screening among ethnic groups, what would be, let's say, the number one lesson that you can give to the prostate cancer community or concerning prostate cancer screening? So is there a number one takeaway from your experience with breast cancer screening among ethnic groups?
That's related to prostate cancer?
Yes.
I think prostate cancer screening, we don't have a national program for prostate cancer screening in the UK, and it's an area of considerable debate. And it's a balance of the benefits potentially of reduction in mortality versus the risks of overdiagnosis and overtreatment, where you're not actually detecting disease that would be clinically significant. I think for breast cancer, it becomes easier to have that discussion with women about going forward for breast cancer screening because the evidence base is much more robust. And there's lots of randomized evidence in breast cancer regarding the benefits and harms of screening, certainly with the women aged 50 to 70. My understanding is that for prostate cancer in the UK, this is currently under evaluation by the National Screening Committee, and recommendations are going to follow as to whether a national programme is going to be rolled out. And I think for people who work in ethnically dense areas, primary healthcare practitioners and secondary healthcare people, the most important thing is for them to be cognizant about the population demographics locally and to work out who is eligible, and for those who are eligible, to encourage them to attend if invited.
Thank you very much. I would also like to invite all the speakers. I hope you can stay on the webinar until we're finished to maybe answer some questions. And to you participants, again, you're welcome to post any questions or remarks you have in the Q&A function. So please feel free to do that. So thanks again to all the speakers. We're now going to move on to the panel discussion on combating ethnic disparities in healthcare, translating knowledge to action. So how do we translate the knowledge we have now into actions? Before introducing our panelists, a couple of questions to think about, and feel free to give your perspectives during the panel discussion. I also invite our previous speakers to share their views. First question, what are the structured and cultural reasons behind low screening uptake among at-risk populations? And how do we bridge that gap with targeted, trusted approaches? The other question I would like to think about is migrant populations often have lower cancer risk due to age, but when symptoms do occur, they are missed. Now, how can public health systems evolve to recognize non-traditional risk profiles? Now, a warm welcome to our distinguished panel members. Raman Bedi, President-elect of the World Federation of Public Health Associations, Michaela Mal, Anti-Racism Coordinator of the European Commission, Eric Bryers, Vice Chairman of Europa UMA, Christina Guerrero-Pais, Director of the Borstkankervereniging Nederland, that is the Dutch Breast Cancer Association, and board member of Europa Donna, and Lee Kamori Haynes, Associate Professor of Practice, Director of Master of Public Health Program at Simmons University. I want to now invite each of our panelists to share in no more than 1 minute a short quote or phrase that captures your perspective on the topic, combating ethnic disparities in healthcare and translating knowledge into action. Can I start with you first, Lee?
Yes, thank you. It's really wonderful to be here. And when I think about that, I guess, phrase, the theme for the session, I think about it in the context of the theme for Global Public Health Week, which is decolonizing public health. And so in that context, I think about, how can we, and I think that's part of why we're all here, like how can we rebuild, even develop new institutions and processes that kind of shake off the hold that colonial thoughts and approaches and practices have on the way we continue to think and do our work, which perpetuate exclusion and extractivism from the health system and from public health.
Thank you. Eric Bryce, I see you on my screen.
But I first unmute myself, otherwise you wouldn't hear me. So it is a tricky problem we are facing, because it is, for instance, in the data, we do not have the data. We are talking about a number of cancers detected, but we have no idea of which percentage of the real cancers we detect. Even if we saw the presentations, we find that there's a lower prevalence of breast cancer in the different populations, but we have no idea which percentage of the black number do we find. We say that in the white women, we find a lot, 199 something, and then in some of the black communities, perhaps 119. But what does that mean? So we lack a lot of information to be able to really analyze. But this does not mean that we do not have to put every effort we can to get as many persons into the screening programs as possible. Otherwise, they just don't stand a chance to be detected.
Okay. Thank you. Raymond.
Thank you. Just say, you know, how great it was to have those presentations. They were really insightful. I think we're not going to challenge some of these issues if we continue to consider the minority or the Black community as a single homogeneous group. And I think we're going to have to become more sophisticated in looking at variations within ethnic groups, intergenerational issues, and maybe in some communities, the significant role that gender plays. So I think as we develop our experience, as we are developing our experience in ethnic disparities research and understanding of the community, I think we will have to look at the core base of what we're defining and to maybe subgroup some of those issues. Thank you.
Thank you as well. Then let's go to Christina.
Thank you. Thank you very much for inviting me. It's an honor to be here, first of all. And I think there are a lot of topics we can address, but I'd like to point out two of them. First is research is the base, is the foundation where we can look at. And we know that in research, mostly the high qualified patients are being included. So that means that a lot of other people who at the end receive treatments, the different treatments are not tailor-made for them. And then on a more personal level, I really think that if you need to treat a person, you need to know the person. And that is something where I resonate with the previous speaker, that we have to break it down until the level of the person we are trying to treat, and to really try to understand who is this person, not only genetical, but also as a person as a whole in front of me that I want to treat. So I'm focusing now on the treatment, not on the screening. Thank you very much.
Thank you, Christina. And then last, but definitely not least, Michaela.
Yes, good afternoon, everybody, and thank you for having me. Such interesting interventions from the previous speakers. So I will try to provide today the European Commission's viewpoint to today's topic. And of course, health equity is a cornerstone to the European Commission and the European Union values. But we still know that disparities, as we have heard already today, exist in, for instance, Roma communities, but also in other racialized and ethnic minority communities. And too often, as we've heard also today, discrimination and lack of culturally sensitive care, gaps in data, the data collection of desegregated data lead to delayed diagnoses and poorer outcomes. And here the EU is trying to take action by strengthening anti-discrimination measures in healthcare, community-based outreach, funding, of course, and policy tools such as the EU anti-racism strategy, which I will tell you a bit more about in my next intervention. Thank you.
Thank you very much, and thank you also for being here. Now, I have a question for the panel. Who do you think should be held responsible for ensuring progress on reducing inequalities in cancer screening and care? Is it, well, I can mention a few that might come to mind. Should it be governments? Should it be the EU? Is hospitals, the public? Who would like to go first? And let's try to keep the answers a bit short so we have some more time to dig deeper into other topics as well. Eric.
So if you look at this is health healthcare. So in healthcare, we all know that it is not the EU who will define what can happen in Europe, because this is for the member states. So my feeling is that it is a responsibility of the member states and of the governments of the member states, and then the correct part of that government, because we have regions, and regions may be important in preventive medicine, like in my country. So it is that part that should be responsible. They should organize screening, and they should do it in such a way that there is equality for all the different subgroups. Although that is at this moment, as far as I know for my country, not the case.
Christina, I see a hand up. Sorry, I was muted.
No problem. I thought let's do it the correct way. I think it's an interesting and very complex question. If we knew the answer, we already would have solved the problem. So that's a bit of a trick question. But I do agree that in essential, not only governments can play a role, although they don't always do. So that's a difficult issue also addressing. If I look into the Netherlands as example, we're having trouble with the government requiring their main form to be able to address issues and move them forward. I think also hospitals have a role, but at the end, even then, also doctors, screening programs, all of the above, as you mentioned, I would suggest do have a role to be able to not only provide better screening facilities, but also create more awareness that to raise awareness that there is a risk of getting cancer in one way or another and how to prevent it. But again, I think the question is really complex and there is not one solution.
Sure.
Raman, go ahead, please.
Robert, thank you. Yes, I agree. Obviously, governments and health organizations, but also our educational institutions. I think our training institutions to train future healthcare professionals should be fully aware. I think the private sector and the employers should also be involved. Those that provide well-being for their employees, health insurance, etc. Obviously, community NGOs we've done, and society. So in summary, everyone should be really involved. But we had a really classical example today. We had a research agenda really well described by Rose and Eva. Now we should learn from that future ethics approvals for similar type of studies should incorporate these type of learnings. And funders should not be funding projects that do not actually incorporate these things. So I think this collective learning should be ingrained within our institution and their processes. Thank you.
Thank you. Anyone? Eva, please go ahead.
I agree with that for funding, when researchers or clinicians are applying for funding, they should include costings for outreach work, because if you're going to be diverse in terms of your recruiting populations, you need to understand for the Black community, for example, or even some of the other communities, like say the Asian communities, we would need to do outreach work to engage them. And if that is not costed for, mostly in research, usually that is not costed for. So I think funders should be reminded that projects should always include outreach.
Thanks. Thank you, Eva. Anyone else want to comment?
Maybe I can just add, as mentioned by a colleague, that indeed the Commission does have limited direct authority over health policies, as it's member states' competence. But here, it can influence at least health outcomes through ensuring strong legislation and ensuring, again, funding, which is one of the main mandates of the Commission, through programs like the Horizon Europe and initiatives that are aimed at improving public health across the EU. And this could be done through setting, for instance, overarching health policies and guidelines also, we are an institution that does bring member states together to collect, for instance, good practices, which have been, for instance, mentioned today already, a few of them, and promote these good practices and facilitate collaboration among member states to ensure indeed that if there is a good example, that could be used as a baseline for instance, future work or future research. So I think the Commission certainly does have a role in supporting member states in ensuring that we can support, at least be a supportive mechanism, I would say.
Is it safe to say and conclude that there's, let's say, a shared responsibility here, and that there's no one party that is fully responsible, but it's a shared responsibility? Is it safe to say that?
I would just like to jump just 5 seconds to say that
Please do.
health is an issue of, and especially health inequalities or health inequity, it's an issue of justice. It's an issue of human rights also. And when it comes to ensuring justice and human rights, that is a responsibility of the government. And so I think that while, as you're summarizing, this is a collective effort and everyone has a really important role to play when it comes to making sure that people are able to enjoy their right to health and that we do have health equality or health equity, then ultimately I see that as more of a government role that everyone can support.
Thank you. I have another question that I would want to put forward to the panelists, but due to time, I have some questions for the individual panelists. I'll go to those first. Christina, two things actually. One, the first thing, and you don't have to answer this right away, but consider it my second question or second remark, because you mentioned if we knew the answer to the questions or the let's say problems, we would have solved the problem. So I just want us to reflect on that, because we are discussing ethnic disparities for, in my opinion, as as a moderator, my opinion is that we know solutions for the problems, but yet we have not solved them as yet. So I just want to put that forward first, just as a thought. Christina, how can we improve communication between healthcare workers and patients, especially when they are from disadvantaged groups?
Thank you, Robert. Thank you for your questions. And I will start with the easy one, the second one, and then come back to the first one. Well, in the Netherlands, we did a research project where we first define, to start with, who the disadvantaged group is. And what solutions could be reached out on communication. Well, at the end, about 30% of the Dutch population is low or limited health literate. So that means that it's, well, 3 out of 10. And the definition is, it's about the definition where you are not able, you are low skilled people. It can be elderly, low skilled people with a migration background. And when we took into account those groups, we worked together with those groups. And at the end, we developed 10 recommendations for developing information material. So it's regarding how to approach the group with information. And I will only name a few as an example. The most important one was always keep the language at B1 level. So keep it at a level that everybody can understand. That means a clear title, sub-readings, that means simple words, that means short sentences, things like that. Maybe people think, oh, that's easy. Well, it's not always as easy as it looks, but that's one recommendation. Another one that's important is to say, don't make it too simple, because if you make it too simple, then people can misinterpret what you're saying. And the third I would like to mention is that use images. One of the presenters before also mentioned that. using images, you can really get your message across a lot better. We use these 10 recommendations in everything we do, and well, the final straw that we have hanged on to is, thanks to AI, that we're able to have a translate function on our website, so that also all the information can be translated. So these are some highlights. People are interested, I can share more information about it, but this is one of the things we took into practice to be able to help well, groups on that matter. And if I may come briefly back on your first question, it's not only about the solution, but also maybe what I was trying to bring across is, yes, I think we can, with each other, name the top 10 solutions that must be implemented. But I think where we then can experience some difficulties will be in which group or person of government or whatever organization is needed must take what step and work together with what other groups. And that's where we have such a complex system where money is really important, funding, and we're not able to push through and to really make solutions work. So thank you for that reflection.
Thank you, Christina. Thank you as well. And I think you mentioned something that's very important. One of the goals that we have today is not only to talk about the issues, but to also hopefully come up with ideas of how we can address the issues and hopefully one day solve the issues that we are continuously confronted by. So thank you. Eric, if healthcare access may be equal on paper, but healthcare inequalities persist. Now, how do we ensure equitable access to preventive medicine in the context of cancer and beyond? You might be okay, yeah. I was just going to say you might be on mute, Eric.
Yeah, I had to unmute. So in our Western world, in principle, we have equal access to healthcare. In principle. So that is, for instance, in Belgium, everyone can go to the hospital, has access to doctors, can choose their own doctor, etc. But that does not mean that everyone will use that equal access at the same level, because there are a lot of hurdles to be taken. You have a hurdle that, and I think the most important hurdles are really personal, as we already heard in the discussion. We have persons who, from their background, are inhibited to talk about some certain problems. And if you talk cancer, so there is this double taboo. Cancer by itself is a taboo, and then if we take the male cancer, prostate cancer, there's a second taboo. So that's a taboo on a taboo. So from their background, it will be very difficult to talk about it. And if you say we have preventive medicine, so we have a system, which we don't, to be clear, there is in no European country, there's really a real screening process for prostate cancer. But if we would have that, it would still be, you can make it as equal in access as possible. Everyone's welcome, everyone is invited. That does not mean that they will go. And I have no specific from my country, specific studies that show the unequal participation, because we talk now about participation in screening processes. It is from, I'm sure that it is not equal. So it's not the same percentage of ladies, white ladies who go for a screening for breast cancer as for Black ladies. That is not the same percentage, because they have their own, there are socioeconomic aspects, there are aspects of fear of not understanding, fear for the result, that make they are not equally participating in what's offered as screening and preventive medicine. Unfortunately, because if we would look at the level of development of cancers when they are developed in underprivileged persons, they very often are detected with a cancer that is much more advanced than in those who come at the demanded age for screening, they may be found more readily in a curative stage.
I see. Ava, you have, do you have a brief question you would like to put forward, or a
Yeah,
remark?
just a quick comment, just to say that what we find, like say with the profile study, is that it's not difficult to reach the community. What we need, more work needs to be done to engage the community. So these men, they find it difficult to go through the door, like to go to their GP, say for a PSA test. But we need to make sure that, once they actually get to their GP, how do you maintain them so that they can actually have that discussion with their GP, which already we know is a difficult subject for them to discuss. And beyond that, even those who are diagnosed with prostate cancer, how do you keep them on that journey, on that prostate cancer treatment pathway? So it's a lot of work to engage them rather than reaching them.
Thanks for adding that comment, Ava, very important. Raman, a question for you. How do we address distrust and cultural disconnection between health systems and marginalized communities?
Wow, I don't know how long we got to that. Yeah, it's a really important question about distrust and cultural disconnect, and it'll be many layers, and it'll be very difficult to answer that in a few minutes. But if I had to start somewhere, and if I had to put my money somewhere about bringing about the change, I would put it into internationally trained health professionals who are relocated in that country. In the UK, we have many people who trained overseas who are connected closely with the culture of that community and understand it. We call them in the UK experts in our midst. These are experts because they have that inherent understanding. But it's naive to think that just because they trained in those countries, that they have all the skills for advocacy and bringing about change. And we have to train them. But that's where I would put my money as first place. So it's a complex question of how we do it about mistrust, but there is some low-hanging fruit, and that's where I would start. Internationally trained health professionals who can communicate with their heritage countries and with heritage communities. Thank you.
Thank you so much, Raman. I totally agree. I think that is something that we need to tap into, and that is definitely insufficiently done. Rose, please.
Hi there. Just in addition to Raman's excellent point, I agree. And I think that's where the importance of PPI, so public and patient involvement, is so vital to the design of services. Because we find that if you're trying to create a service to increase representation from a certain group, having a panel who are involved with every step of the development process is so important, and it ensures that you'll actually get a good reach and a good uptake to that service. So I think, again, like we said earlier, there cannot be too much emphasis put on the importance of PPI panels and co-production.
Thank you. Thank you. Michaela, question for you. How does the next EU anti-racism strategy address inclusion in different sectors, for example, like employment, education, and housing? And do you see ways in which health equity can be addressed?
A great question indeed. We are currently in the process of working on a drafting of a new anti-racism strategy. So ensuring that the work on combating racism moves forward beyond 2025. Our current anti-racism action plan comes to an end. And I think the major deliverable of the current action plan is it's the very first time on the EU level that there's a recognition of structural racism. And this a little bit shifts, I mean, it's a major shift in the sense that it moves away from only recognizing racism or racial discrimination as something that happens on an individual interpersonal level, recognizing that it's actually something that happens in our structures and it's systemic. So it's not a small feat, but I do believe we still are not have not been able to fully operationalize the combat against structural racism specifically. And here I think we have to move forward in the upcoming action plan in actually ensuring that we have strong, not only ensuring that there's legal protection in these different areas, but also ensuring that the policy is such that we actually move forward on combating structural racism. And here, of course, with member states, we are encouraging them to have national action plans. Coming back to what Lee mentioned, that it should be government's responsibility. And with these national action plans, we're asking member states to have a comprehensive approach in these different areas, from the recognition of systemic and structural racism. So also in the area of health. When it comes to legal protection, the applicable EU regulatory framework is again in place in principle. There's a strong protection from discrimination with the Racial Equality Directive, but we still know that discrimination is something that, of course, takes place, but we need to ensure that also there's strong legal protection in the area of healthcare, as well as access to goods and services. Also, our aim is to strengthen disaggregated data collection. Here we're asking member states, we've been doing this work for quite some time on working together with member states in ensuring we move towards a harmonized approach in disaggregated data collection, which is extremely difficult with some member states, especially when it comes to disaggregated data on race or ethnicity. So this, of course, is a big problem. Of course, the area of health, especially, we need to ensure that fundamental rights are taken into account, etc. But still, there's an understanding that due to the GDPR regulation, the data protection regulation, we are not able to anymore collect such sensitive data. So the work we're doing is trying to bust this myth, because it actually is possible to still collect data. And I would say also the very important aspect of the upcoming strategy we need to strengthen the intersectional approach when it comes to the other policy areas of the Commission, such as the EU Pillar of Social Rights, and ensuring that the EU for Health program or the Europe's Beating Cancer Plan are also strengthened in the upcoming strategy.
Thank you for that contribution. I think we can go to a question in the chat. How can we define, just a second, please. How can we define ethnicity in terms of a data variable that is scientifically and clinically relevant? And the question is for Michaela. And the question for Michaela is EC Commission thinking about how to collect the data if we have a data variable that defines ethnicity? So the first general question for everyone, how can we define ethnicity in terms of data variable that is scientifically and clinically relevant? And a specific question for Michaela, is the European Commission thinking about how to collect the data if we have a data variable that defines ethnicity? I think you touched on it partially already.
Yes, I would say what we're trying to ensure from the, I mean, it's challenging when you have 27 member states with a very different approach to the topic of that which I'm working with, namely racism or combating racism, from we don't have racism to, from especially when there's not necessarily a long history of migration in a given member state to also the denial of structural racism. So it's a challenging field in and of itself. And what we're trying to move, as I mentioned, is towards having a harmonized approach. The challenge we're seeing with when data is collected on race or ethnicity, there are proxies being used that are not necessarily helpful for getting this exact information. And this is exactly what we're trying to move towards, to have making sure that across the EU, we manage to collect the data in a way where it can be comparable and reliable. What we're seeing, for instance, we're seeing proxies such as proxies that are being used to collect data on race or ethnicity that are such that, for instance, birth country of parents or mother tongue. So that means that already in the third generation, the blackness or brownness of what we're trying to collect, or the information we're trying to collect, is not anymore relevant. Because I use myself as an example. I was born in Finland and my mother tongue is Finnish. So if this data was collected on my daughter, it's already we're lost the information. So this is exactly what we're trying to move away from, to use actually exact data points to where we're not using proxies that are not relevant. And this could also mean using certain principles related to data collection in ensuring that self-identification would be also a possibility when collecting such data.
Thank you. I have one more question in the chat, but it's a question that will require you to time a yes or no. Is migration data a good surrogate for ethnicity data? Anyone care to say a yes or no?
No.
Michaela?
It's not enough.
Yeah.
Rose?
I agree. I don't think it is enough. It's inaccurate, and it doesn't really, in terms of cancer risk and cancer outcomes, we need to focus more on genetics than where people are born. Both are relevant, environment and ancestry.
Thank you. Thank you also for giving a concise answer. Thank you very much. Lee, I haven't forgotten you. Question for you. You have done quite some work on social movements, even on a global scale. What are the systematic barriers that make progress towards decolonizing public health so difficult?
That's a big question, but I think that, at least in my work now and what I see and experience, and even what we talk about in various social movements, I'm a part of the People's Health Movement, which is global, but also does regional work. And one of the huge barriers, systemic barriers that we run into is this kind of prevailing logic of how the system works, and which I'm sure most people here know or would agree that, we kind of have this market logic, and, like, what does a person or what does a company kind of get out of an interaction or a transaction or the health system. And part of my work right now focuses on privatization and financialization of the health system, which can seem far removed from health inequalities, health inequity, and also racialization and racial disparities in health. But when we think about how large companies, private equity investment, for example, in the health system takes resources out of where they're needed the most, that trickles down and leads to health disparities and health inequity. And there's also, issues of access to medicine. I am working with a small group, or I shouldn't say a small group of people, but a group of people called the Public Pharma for Europe Coalition. And it's kind of imagining an innovative approach to medicines research and development, and thinking about how can we have like a European level institute or center that actually produces medicines instead of depending on corporations and pharma companies to do that, so that more people, especially in the context of treatment for cancer, can have access to medicines without it being scarce or overpriced. And I'll just finish and say something that I heard recently, because like these kind of extractive practices and this exploitation is a legacy of colonization. Like we live under it, and we have to imagine how to get out from under it. And so a colleague of mine said that we kind of have a colonization of the imagination. And so it requires like a really big vision, but also a lot of work for us to kind of, rip off the, or I guess break the chains, if you will, of colonization.
Thank you. I guess also quite challenging, because to take the first step, we all need to be willing to have a very deep look at the role that we all have been playing, and also try and understand the past from a different perspective as well. Raman.
Thank you. I know time is short. I think we should look also at digital transformation, how it can help us, how this whole new technology can help us understand communities' position, action, and medicine. So I think there's a powerful tools that are being presented to us, and that would be something that would be worth exploring to better understand how we could target and engage. Thank you.
Thank you. Thanks for the input. Really very interesting. And I think we have, within the past hour, definitely have mentioned a number of steps that we need and can take, or actually we must take, to bring about change. Eric, did you want to make a very short comment?
Yes, because it is the same as we have. So in prostate cancer, there is one thing that we have to do and have to absolutely get done, that is collaboration. We have to collaborate with all the levels that can bring us this better healthcare for everyone. So we have to collaborate between the patient organizations, with politicians, with the clinicians. No one has the answer by himself. So we will have to do it together. And that is also a huge task, because that's not so simple to bring all the players together, find out how we can improve the healthcare and the system for everyone. Thank you.
Okay, thank you, Eric. Christina, I see your hand up. I will ask the last question that I have, and hopefully your remark can be somehow intertwined in the following question and the responses. Now, we've talked, Eva has talked about, she mentioned how they address recruitment by going into the community, posters, taking into account what kind of posters and where the posters should be shown. Eric, you just talked about, you mentioned collaboration, etc. So I have a question not only for the patient representatives, but for everyone. Is there a need for improved representation within patient organizations? Don't be silent.
A very good question. Well, let's start. Maybe I can start. If I look at our own organization, organizations that I know of within Europe, yes, the need is there. because if you look at if we do totally are representative, we are not. So that's a challenge we are heading upon us. But one of the thoughts I also was having, that if you look at the future, medicine can help us. If we really can make progress into molecular medicine more, it can help us be able to have a more personal approach.
Thank you. Eva.
Yeah, so I agree that I think, yes, that would be beneficial. Some of the feedback that we often hear from patients is that it helps if they're faced with somebody who looks like them. But we have to appreciate also that sometimes that is not a possibility. For example, in the UK, you may not necessarily find, a black clinician or a black surgeon, treating these individuals. But as we've mentioned within from other speakers, if education is there for the clinicians so that they are aware of how they approach or they engage or speak to these patients in front of them, then it doesn't necessarily make a difference if that individual doesn't exactly look like them. But as long as they can hear the patient, their need, and also support them in the way that they should be, then perhaps it shouldn't make a difference. But patients sometimes do say that it helps to have somebody who looks like them.
Okay, thank you. Raman?
Thank you. Yes, I agree with Eva. But can I just, as a caveat, say, just because someone has particular characteristics or come from a different cultural group, it doesn't give them the skills to engage at a level that we would want them to engage with the community. So the only point I want to simply say is, yes, it's excellent to have people that identify with certain characteristics of the community, but let's train. Let's put the training in. Let's give them the skills and not just assume that they will have them because they come from a particular minority ethnic group.
Yes, thank you. Any last comment before we close the discussion panel? Anyone? Eva?
Just to point out also that we should also remember that there is great emphasis from support group leaders or community leaders. They play a huge role. I think somebody mentioned it in the chat. They play a huge role in terms of disseminating some of the information that researchers or clinicians may want to put out there, or the charities. So as long as we don't forget them and associate with them or collaborate with them, it helps to make a huge difference in terms of the messaging that we're trying to do, and also to engage the community.
Thank you. Thanks everyone for participating in the panel discussion. And again, we looked at combating ethnic disparities in healthcare and also trying to translate the knowledge that we have into actions. One of the things that comes to mind is, Eric, what you mentioned, collaboration. Also, what Eva mentioned previously about keeping in mind who we're actually speaking to, trying to meet them, let's say, halfway. Like Eva said, it went to churches, barber shops, etc. So really, thanks everyone for their contribution, and I want to pass on now to Milka Skolovic, who will give her last remarks and conclusion of the session today. Thank you, and thanks everyone for joining.
Thank you so much, Robert, and good try on that Slavic last name. It's always a challenge. And also thank you to all our speakers and panelists, and of course to our audience for this rich and thought-provoking discussion, also for the comments and the chats. Before I reflect on what we have covered in the past 90 minutes, and I don't know why did I ever accept that challenge, I wanted to highlight why is this conversation actually happening today. First of all, both hosting organizations have been driving this agenda forward in Europe. The European Cancer Organization through its Inequalities Network and Ethnicity Workstream, and EPHA through the DISCO Stakeholder Network on Anti-Discrimination and Health Equity. But now, with the new European Commission, we have an opportunity to push for stronger action on health inequities. We recognize that it's crucial that we do not stick only to the European context, and that the action against racism and discrimination in health must reflect the global context, which is why we envisage this event as part of the Global Public Health Week. So what is it that we have learned about ethnic disparities in healthcare through the lens of cancer, but also beyond? We learned of clear, concrete examples of challenges in cancer care, especially around prevention, early detection, and equitable access to treatment, but also of possible solutions. We got very focused insights into prostate and breast cancer that showed not only how ethnicity shapes the experiences of care, but also how gender plays a role. And this underlines the need for an intersectional approach to health equity, as Raman was referring to. We reminded each other of the critical need for improved disaggregated data collection. So thank you, Michaela, for that, which remains a challenge. My personal highlight is the point of trust, which was touched upon by pretty much every speaker today. And I would like to quote Christina from the early moments of the panel, who said, if you need to treat a person, you need to know the person. And I would like to extrapolate that to, if you want to serve the population, you need to know the population and all of its communities. And for that, then my personal takeaway in terms of solutions is the culturally appropriate outreach. And here I will be referring to just a few moments from the discussion, because I won't be able to repeat them all. And one of them is co-creation, as in the example of the profile screening study, including the role of health workers from minority communities, where then education and training responsibility comes into play, as raised by Raman. And also improving health literacy, as discussed by Christina. What we have discussed here is not necessarily revolutionary, right? We know a lot, we know how much we know what needs to be done. And what we seem to be seeking now is a way to structurally implement that knowledge. And I hope that we will find a way to liberate ourselves from that colonization of imagination that Lee was so eloquently bringing up. And maybe indeed through the digital transformation that Raman mentioned. And I hope we will be able to do it together as Eric suggested. So keeping it short and aiming to close at the time, following today's webinar, we will reflect on the discussion and we will use it to refine our own recommendations and further work to ensure that these conversations do lead to meaningful changes. And we will share that with you at a later date. And we will do so in our own field, but we hope that we will be able to collaborate with you as well to ensure that each and every one of us can access healthcare in the same way, no matter our background. And with that, I just wanted to take a moment to thank the people who have made this webinar possible, offering us their time and their attention and support to allow us to have this rich conversation. So a big thanks to our moderator, Robert, our presenters, Eva and Rose and Toral, our panelists, Raman, Michaela, Lee, Eric and Christina, to Norbert and Aleka at the ECO, who came up with the idea in the first place and prepared most of the concept and the agenda, to Tom, Bhavani, Mladen and Sipokazi from EPHA, for working hard in preparation and in the background to make sure that this webinar runs smoothly. And of course, to the World Federation of Public Health Associations for kindly hosting our webinar in the Global Public Health Week. So thank you all for attending and for participating, and you will be hearing from us in the follow-up.